Okay, can everyone hear me? Okay, I have two main jobs. One is to keep you from eating lunch too early. And the second is to talk about all the red light things that Dr. Chopra mentioned. I'll try to be out of character, not be an anesthesiologist and put you to sleep. What I'd like to do is to really have you become familiar with some of the well-known interventional therapies for CRPS. By interventional, I mean things that involve needles, basically. And then become familiar with some of the new and emerging interventional treatments that are available for CRPS. What I want to talk about first is just a very quick definition. And Dr. Chopra has already covered that, but I want to show you that from a slightly different perspective. And that is that one of the problems with CRPS is that because we're still learning about it, we know very little actually, that really complicates treatment. Because if we don't know how pathophysiology completely, it makes it very difficult to learn to really design something that really works effectively for everyone. And still, even today in 2017, there are some people who don't even believe it exists. As you see here, this is this is from 2017 publication. It says there are serious questions of whether it exists at all. So again, there are some people who really don't believe what you have. So the important thing is, as Dr. Chopra mentioned, if you talk to one of those people, lay down that chalupa and back slowly away, because they're not going to be much help to you. It's very confusing because, again, we don't fully understand it. This is a chart that was created by one of our Nashville psychologists, Dr. Stephen Brule. Dr. Brule is the person who helped to lead the creation of what are called the Budapest Criteria. Now you might ask, why is it called the Budapest Criteria? It so happens that every year, one of my good friends, Gabor Rax, who's a native Hungarian, has a pain conference in Budapest. And that's where a lot of the big pain guys come in and we talk over things and we look at different solutions to different problems such as CRPS. And this group of pain physicians got together, it's about 25 to 30 of them, to try to look at how best to diagnose CRPS. And out of that came a paper called that we now call the Budapest Criteria. So I'm not going to talk about all these, I'm going to talk about mainly the interventional things that involve procedures. I'm going to skip through some of these slides quickly because lunch is coming. What I'm going to talk about are the things that are underlined here, the interventions, procedural interventions, and regenerative medicine also. I want to talk about that because you're going to be hearing more about that in the near future. And I want you to be aware of the pitfalls in looking at regenerative medicine as a therapy for CRPS. There's some bright spots, but lots of dark spots as well. I also want to mention this ketamine. You know, I was talking with Dr. Chopra, I've found that to be a very, very effective treatment for some people with CRPS. We do that in a little town called Tullahoma here in Tennessee, about 80 miles south of Nashville. But there's a hospital there that has a very visionary CEO who allows me to do the IV ketamine infusions with insurance coverage. And so that's something some of you may have an interest in. We found it to be very helpful for some people, not for everyone, but for some people. And so we're delighted to be able to offer that service. I'm going to talk about these types of procedures. I'll give you an idea of why they came to be and whether they help or not. The thing to remember is for this page is that not everything works here for everyone, but all these things have worked for someone. So that's the thing to remember to take home. What's called the IV regional blockade, or the Beer block, was invented by August Beer in about 1908. Just an old procedure that was originally done just for anesthesia. However, it was found to be helpful for some people with CRPS, probably CRPS type 2, when certain medications were used in this block. And I'll show you how the block is done so you're aware of it if you've never seen it or heard of it. Guanethidine, which is a blood pressure medication actually, labetalol, which is another hypertensive medication, and lidocaine have been found to be helpful for some patients. Now currently it's not done very much because insurance doesn't pay for it anymore in hospitals. And this is how it's done. And this shows why it might help some and not help others. In order to do it properly, you have to first squeeze the blood out of the arm that's affected or the leg that's affected. So you remember, if you have CRPS, that's not going to feel good. That's going to really hurt. However, it may be worth it for some people. After the blood is squeezed out, a tourniquet is inflated in the arm or leg above arterial pressure so that the veins stay empty. And then the veins are filled with medication, such as guanethidine or labetalol, for about half an hour to 45 minutes. Now, for some people, it gives them outstanding pain relief. However, as you might imagine, it's very painful to put in. Sometimes they have to use general anesthesia or heavy sedation just to be able to activate it. Now, talking about sympathetic blocks, I'm sure you've heard about stellate ganglion blocks and lumbar sympathetic blocks. Those can be helpful to some people. Again, I think it may help mainly with either very early CRPS or CRPS type 2. Success rate is roughly about 30%. And so I think it's still worth trying, but it may not help everyone. And the stellate ganglion block is done right beside the voice box. There's a nerve center that controls pain fibers coming from the arm and from that side of the face and the shoulder. So again, for some people with very early CRPS or CRPS type 2, that may be helpful. The lumbar sympathetic block is done right beside the lumbar spine, not in the spine, but beside it, at usually about the second or third lumbar levels. And a very small needle is placed beside the spine under X-ray, and medication is placed beside the spine to numb the nerve chain. It's about the size of a shoestring that controls pain fibers from the lower back down to the toes. And that can be done at either side. I want to move on to an interesting type of stimulation called Scrambler Technology. This is an attempt to actually confuse the nerves that give feeling from the skin of a limb or an area up to the brain. So again, what we're trying to do is to actually confuse information going to the brain that's not interpreted as pain. This is a fairly new technology that started in Italy. And what it does is use 16 types of nerve action potentials to put in a sequence to confuse the central nervous system. This is kind of what it looks like. It looks like a big TENS unit or a big electrical stimulation unit. But what it does is to basically try to confuse the spinal cord and the brain and eliminate the pain message. There is a protocol for this that begins with 10 to 12 daily treatments at about 30 to 60 minutes each, and booster treatments are available. This technology was designed by a fellow named Marineo, who wrote the paper that you see here. And looking at that for complex visual pain syndrome, as well as other neuropathic type pain syndromes, as well as cancer pain. So it's different than TENS because it's a continuously changing set of frequencies and action potentials. So again, there are not many of these units in the States. They're mainly in Italy, but there are, I think, about 5 different centers that do this type of therapy. So something worth looking into that's non-invasive. I want to move now into neuroaxial stimulation. And again, as Dr. Chopra mentioned, this is a red light area. You want to be careful of this for 2 reasons. One is because we're involving needles that go into the spine. Number 2, you also have to be aware of the people that are doing it. There are some people, some physicians, who take a weekend course and think they're experts after that. And those are the people you have to really run away from. That's not good. You need to know that they've done lots of these procedures and that they had good results. Spinal cord stimulation involves putting basically 2 plastic-coated antennae into the spinal column in the epidural space, the same space that we use for ladies who have labor pain. It goes into that space and then travels up the spine a ways. What you see on the right is the electrodes in place there under X-ray. And from there, we ask the patient with one type of stimulation, which I'll talk about, what they're feeling and where. What we're trying to do is basically get stimulation from the waist or slightly above down to the toes in the lumbar spine. And for the cervical spine, we're trying to get stimulation from the shoulders down to the hands. Now, this can be a very helpful technique, again, for some people with early CRPS and some people with CRPS type 2. The real key is that we have to pick the right patients for that. It happens to be one of the main indications for spinal cord stimulation is CRPS. It used to be considered a procedure of late resort. We're looking at it a bit earlier because of the opioid crisis and things like that. But still, it should be, because of its invasiveness, you need to consider that as a procedure of late resort, because anytime we go through the skin with anything, a needle or anything else, there can be complications and severe side effects. The real key is to work with someone who is very experienced in doing this. It's done as a two-phase trial. The first part is the trial phase for about 7 to 10 days, where we put in these leads temporarily to let you see how it feels, to see if, number one, do you like the way it feels, and number two, it relieves at least 50% of your pain. And there lies part of the rub, because if it relieves 50%, you have another 50% to deal with. And so you have to look at ways to deal with that. So as Dr. Chopra mentioned, any of these procedures has to be done within a team setting, within a multimodality type of framework. It's never a cure itself. If you like the way it feels, and if it takes care of at least half your pain, it may be worth considering for the long term. Now, studies have shown that after about 3 years, the actual benefits tend to wane a little bit. And I think because, again, central sensitization sets in and other things that may need to be dealt with. So again, it has to be done in a framework where you have support for other modalities as well. This is a trial that's done in the office. This is one of my offices here. We're putting in a stimulator for trial. The actual implant is done in a hospital because, again, it's a foreign device we're putting into the body. And so we have to be sure that it's a sterile environment that is set up for the operating room. Now, there are several types of stimulation, and over the years that this has been used, for about 30 years now, devices have gotten better as far as quality goes and durability. They've also looked at different targets, different types of stimulation. The conventional stimulation is one where the patient feels paresthesia. You feel a buzzing or tingling sensation that kind of covers over your usual pain. For that type of stimulation, your cooperation is needed during the trial to make sure that the leads are placed appropriately in the right part of the spinal cord. I'll show you a bit about that in just a moment. One of the problems is during the trial period, the leads can move out of place. If you bend or twist, the leads can shift position. It takes about 3 to 4 weeks for the leads to scar in place, so that doesn't happen anymore. But during the trial, you can lose stimulation and not get good stimulation at all. Looking at patients over the years, we can get the best results for pain relief, for reduction in pain scores, and patient satisfaction. We can get fairly good results for functional improvement, which means you can attack physical therapy more aggressively and be more functional. Okay, that's less successful. Psychological improvements can also occur. The things that are least predictable are the ability to stop pain medications. That's why it's important to use as little pain medication as possible. And again, when you turn off the stimulation, the symptoms can return again, and quite often they do. So again, this is a device of late resort if other more conservative things are not working for you. There's another type of stimulation which has become increasingly popular, which is called high-frequency stimulation. For those of you who may be into engineering, it's stimulation above 10,000 hertz. For this type of stimulation, you don't really feel any buzzing or tingling. You simply feel pain relief. Also, the placement does not really require cooperation. We simply place it by X-ray at certain levels, and then pain relief seems to occur. This is really good for patients who have aphasia or can't really tell us what they're feeling. It may be interesting for children in the future. But the key really is that this actually stimulates a different part of the spinal cord and penetrates much deeper to provide pain relief. And this is the type of unit I'm talking about. It's called the one that we typically use is called a Nevro unit. That's a new manufacturer. And again, that requires a different placement than the traditional spinal cord stimulation. The leads are placed differently, and there's no sensation of buzzing or tingling, which some people just don't like to begin with. We've also looked at what is called dorsal ridge stimulation, or dorsal ridge ganglion stimulation. This is stimulation of a different area than was previously done. Let me see if I can show that to you. In this, the dorsal column stimulation, or traditional spinal cord stimulation, stimulates this area right here. whereas dorsal root ganglion stimulation is over here. So it's a different part of the spinal cord that blocks a more peripheral area, so that helps us to better localize pain. And let me show you a bit about what that means. I'm going to skip this slide and this one as well. What it involves is placing a very small loop of circuitry around the dorsal root ganglion right here. And what that would mean to you is this. If you have pain just in your foot, usually traditional spinal cord stimulation would stimulate this whole area from your waist all the way down to your toes. With dorsal root ganglion stimulation, we can get just the foot. And so you don't feel stimulation all over when you have pain in just one area. So we can better tailor it to your personal needs. There have been some studies done about it, not a great deal because this is fairly new. This is a study of just 12 patients, and a number of those seem to prefer dorsal root ganglion stimulation. Now again, you have to be intelligent consumers. Some of the people doing the studies are paid by companies, so we have to again look at results and look at long-term studies and look at more studies to make sure that it's going to work for your case. Here's another study, again looking at 8 subjects. Again, these are small studies because number one, complex renal pain syndrome is rare, but number two, it's a new technology, so it's hard to get people enrolled quickly. And so in this particular study, again, dorsal root ganglion was found to be more helpful than the traditional stimulation. So something else just to think about for complex situations. Here's a third study, again looking at what's called the ACURATE trial. This is a trial that was designed to, again, look at dorsal root ganglion stimulation and patients with chronic limb pain due to CRPS or peripheral causalgia showed that that type of stimulation provided greater pain relief than traditional stimulation. So again, another type of stimulation in a different area that may make a difference for some people. Now, in regard to spinal cord stimulation, we have to ask this: is it safe? And the answer is maybe. It's really safe in the hands of experienced providers. I'll give you some evidence in just a moment. If a provider is very experienced, they've done lots of these and done lots of them successfully, it can be very safe. And the person who goes to a weekend seminar comes back as an expert, it's not safe, and I wouldn't recommend it. Again, in interventional pain therapy, we have what we call the Yomama Rule. It's something that you have to recommend, that you recommend to your mother, but you have to like your mother also. What kind of complications can occur from this? The main one is lead migration. That's pretty common, and what we try to do is to help patients not to do lots of twisting or bending motions as much as possible. Spinal cord injury can occur, and I'll show you some numbers of that in just a moment. And infection is the next issue, and that has to do with the knowledge of the provider of maintaining sterile techniques. So again, if someone doesn't do it very often, the staff may not be very good at sterile technique, and infections can occur. Also, if a patient has a history of MRSA infections previously, that's probably not a good candidate for this, because anytime you put a foreign body into the body, it can be infected by MRSA. Now, this is a study that was initiated by Timothy Deere, who's a very high volume implanter, and a group of about 30 physicians across the world who do these types of techniques. And this was actually a committee designed to generate safety guidelines for reduction of severe neurologic injuries. So this is a group of experts who got together to look at how the problem was. And this is what they found. As you can see on the chart, serious complications about 2% for both percutaneous leads, those are leads put in by interventionalists, and paddle leads which are put in by neurosurgeons. And so as you can see, the percutaneous leads have a higher percentage of neurologic injury because again, there's a lack of experience there. I was fortunate to be trained by neurosurgeons myself, and so that does really make a difference. When we look at things like paralysis and spinal cord injury, percentages are low for surgical implants, but higher for percutaneous leads put in by interventional specialists. Infection about the same in both. So again, it's an issue of the staff and the environment. And the other complications are much less than that, such as spinal or epidural hematomas, which are usually because people take herbal medications or may take some anticoagulants that keep bleeding inside the spinal column. Cerebrospinal fluid leaks, or what we call wet taps, are again fairly rare, but mainly for the percutaneous leads, typically by people who don't use good technique. So again, it's really important to know the experience of the person who's offering this treatment to you. When should it be considered? Number one, as Dr. Chopra said, when all reasonable treatments, all conservative, non-invasive things have been tried, that's the time to really think about it if several things are happening. If you're having deteriorating functionality, and if your pain is getting worse. That's the time to think about things that are more invasive. Besides, in lieu of that, medications, physical therapy, behavioral therapy are all important and should be tried before this if at all possible. Another invasive treatment to talk about, and this is one of the last ones I'll mention, is implantable drug infusion systems, or what are called morphine pumps in layman's terms. This is a device that's about the size of a hockey puck that has a catheter connected to the fluid around your spinal cord. So this is a very invasive technique, only to be thought about, again, when everything else has failed. Now, it's a very sophisticated device, actually, that can be programmed through the skin to deliver microdoses of medication. The types of things that can be put on are really quite interesting. Local anesthetics can be used, opioids in very small quantities can be used, and there are other analgesic agents that are not opiates, such as ziconotide, which I'll talk about more in just a moment, or baclofen or clonidine. Again, these things will be thought about only if more conservative measures have failed. Now, these are indications for it. Basically, it's inadequate pain relief in spite of everything else that you've tried. Ziconotide is a very interesting drug. It's actually a drug that comes from the poison of a snail from Southeast Asia. This is the Conus magus snail that actually generates a toxin. It uses a toxin in a harpoon that harpoons fish so that it can eat the fish. It paralyzes the fish and it just draws the fish and it eats it. But marine biologists began to study the poison and found out that it has very specific effects on the pain-conducting nerves in the body. So that's how it kind of developed to be used for humans. The interesting thing is it's not an opioid, so there's no withdrawal symptoms if you stop it immediately. Only thing that happens is the pain returns. The problem is that it has a very narrow therapeutic window. What that means is that the dose that provides pain relief is extremely close to the dose that provides side effects. So it has to be dosed very carefully, and very slowly, and very cautiously. The types of side effects are nausea, memory alterations, mood disorders, urinary retention, confusion, and low blood pressure. Those things can happen if too much is given too quickly. So it has to be done very carefully by someone who's experienced in using the drug. Baclofen is another medication. The generic name is Leorosol. That's very helpful with dystonia and tremors. And so what some people do is actually use a combination of spinal cord stimulation and intrathecal baclofen for patients who have really very severe CRPS. But again, this is a procedure of late, if not last resort. I'll skip through this one. The contraindications to a pump infusion system are the same as for spinal cord stimulation. If there's any infection present in the body, like MRSA, for example, if the pump cannot be put deeper than about 2.5 centimeters, if the drugs have preservatives, they should not be used. If the drug formulations have an acidic pH, that would damage the fluid around the spinal cord and could cause some nerve injury. Complications are pretty similar, except for the fact that because there's a catheter, there could be catheter problems. Infections can be present there again because we're going through the skin to refill the pump about every month or so. And so it has to be done very sterilely and with very careful technique. The catheter problems can be catheter occlusion. Sometimes high concentrations of drug at the catheter tip can cause sort of a callus around the lining of the spinal cord, and that can block the catheter. There can be kinky of the catheter. For example, if the patient has an accident, say an auto accident, the pump might be jerked around inside the patient, and that can cause the catheter to break off or to be damaged. There can be medication adverse effects, as I mentioned earlier. There can be programming errors. If See, a nurse is programming the pump and makes a decimal place that's wrong. The patient may get too much or too little medication. So those types of things really demand very close observation and very skilled performance from the providers. So it is indicated for non-cancer related pain. CRPS has been documented to respond well to this depending on the medication and the patient. Now I'm going to talk about something very new, and that is stem cell therapy. Now I'm sure that everyone's heard of stem cell therapy, and I want to get into that because there's some things I want you to be aware of that might come your way. First of all, what is it? Is it safe? What options are available? And do any options for stem cell therapy work best for CRPS? Basically, regenerative medicine, or what's called stem cell therapy, is designed to help the body repair itself. It activates repair cells in our bodies. Each of our organs, and actually each part of our brain, has stem cells, which are called adult stem cells, inside of it that are activated by certain things. For example, when a patient has a stroke, the stem cells in that area are activated by the lack of oxygen. They activate and promote healing. That's why when you hear someone recovering from a stroke, that means the stem cells in that part of the brain cause replenishing and healing in that area. And so one of the tricks to find out is what stimulates the stem cells in each organ to activate, such as in the nervous system. Before 2006, stem cell therapy was very controversial. It was associated with taking tissue from living babies, and that brought about lots of societal issues, ethical and moral concerns. But something happened in 2006. This gentleman, Dr. Yamanaka, found out that if you could take certain adult stem cells, or certain cells such as cells from connective tissue, he used a tissue called fibroblast, which is basically collagen tissue. If you treat it a certain way, it actually reverts to an embryonic stem cell and has that full potential. And so when he discovered that, number one, he won the Nobel Prize in 2012 for this discovery, but this really meant they didn't have to get tissue from babies anymore. And so now stem cell therapy has really been advancing, and I'll show you some of those things very quickly. Now, what are the sources for stem cells? Many, many sources. One of the things that young mothers are doing, they're saving cord blood and products of conception from their babies to use later on for that child, because there's stem cells in that, and I'll show you more about that in a moment, that can help the child later on if they develop some other diseases. There are adult options such as bone marrow, fat tissue, and even dental pulp has stem cells in it that can be used for regenerative purposes. You can also use stem cells from others, because stem cells typically don't cause rejection, although that is theoretically possible. Now, so when do you use regenerative therapy and how? I like to think about it as a risk-based option, in that the conditions with the lowest risk get the lowest types of severity of treatment. We also have to look at the regulatory issues. Right now, the FDA is kind of weighing options as far as making a statement about stem cell therapy. Because according to the current regulations, if you take, let's say, fat cells from someone like me who has a big reservoir, and you process the fat, what has to be done is the fat cells have to be dissolved to isolate the stem cells. Once you do that, the FDA considers that a drug, and that brings in a whole new set of regulations. And so right now, the FDA is currently deliberating on how best to approach this market because of that issue. So we have to look at the FDA also. And so currently, to get some types of stem cell therapy, you have to actually leave the country to get that done. So let's look at low-level disease. You look at things like wellness, graceful aging, and orthopedic pathology. There are certain types of low-risk therapies, like autologous therapies, such as alpha-2 microglobulin and platelet-rich plasma. Now, why am I mentioning those in the CRPS seminar? That's because some people who do these things may offer it to you as a hopeful gesture. So you really need to be aware of that. There are allergenic therapies such as amniotic fluid. So the bag of waters, the conception products, can be used for regenerative medicine. And I'll talk about those in just a moment. So platelet-rich plasma, I'm sure you've heard of that. Lots of athletes get it for torn tendons and things of that nature. It's a platelet concentration, basically. Now, why platelets? Because platelets have lots of growth factors that can be very helpful as far as regeneration goes. Looking at amniotic fluid, that's a product that is taken from the second trimester, from amniocentesis, or the third trimester, or even from elective C-sections. So what you have to ask yourself is, how good is the tissue being taken at that point? Has the mother been tested for HIV or other bacterial or sexually transmitted diseases? So it's important to know the source of that if you're going to use that. Most of the great tissue banks that are part of the American Association of Tissue Banks, they have certain criteria that they ask for the mother to get that information. There are also some cells in amniotic fluid, and those come from the baby, but they're shed. They're not taken out of the baby. They're shed by the baby into the amniotic fluid. Those are cells from the skin, from the GI tract, from the GU tract, and the respiratory tract. Those cells are taken out of the amniotic fluid so that it's just a pure fluid. Now, what's important about it, it contains normal growth factors and bioactive compounds that be helpful for regeneration. It has some current uses, but again, those may spread to CRPS by some people who do this. So I just want you to be aware of that so you know what they're talking about. Now, these types of stem cells, that I'll show you in just a moment, have been shown to be helpful in animal models and some human models for Crohn's disease, lung disease, diabetes, repair of bone defects, heart disease, kidney disease, and neural degeneration. There have been quite a few studies with stroke showing improvement in stroke functions for patients who've had neurologic disease. So again, it's a be headed your way. And I'll show you one study for CRPS and stem cells at the very end. Now, where do these cells come from? Basically come from the products of conception. Now, I've done obstetric anesthesia at Vanderbilt for the past 25 years, and we would take these products and put them in the garbage, basically. Now we're finding out they're an excellent source of stem cells that can be used for good purposes if used appropriately. For example, the cord blood. If you look at the umbilical cord, from the veins themselves and the arteries, there are stem cells that can be used for certain purposes. Also from this gray area called the Wharton's jelly, there's stem cells there that can be used for regenerative purposes. And there's some information about that for diabetes and for brain injury. The Wharton's jelly, which I just showed you, has been used again for help people with type 2 diabetes, when this is given for such things as open wounds, to help the open wounds to heal, improve circulation. Now, who should give you stem cell therapy? Again, it comes to you have to know the provider. They need to show some evidence of education and training. Currently, there are no residencies for stem cell therapy or regenerative medicine. There are a couple of fellowships. They're not ACTME approved. They're not American Board of Medical Specialty approved, but they do show the person has had some education, that they know what they're doing, basically, as far as we know currently. The other types of training are basically what we call the weekend warriors. They go to a weekend course and come back an expert. Those people you need to stay away from. Talking about neuropathic pain, again, there's only one study for CRPS currently that I'll show you in just a moment, but there are numerous experimental studies showing some regenerative effects and trophic effects for neuropathic pain. Some are in rat models, but there have been some human studies as well. This is one quote: "The ability of stem cells to modify cellular processes for protective and restorative microenvironment that can potentially reverse the causes behind the onset of neuropathic pain." So our hope is that with these types of studies and this type of therapy, we actually reverse some of the changes that CRPS has caused to the nerves in your body and in your brain. Again, the literature today is very limited, and most of the studies have been done on animals, but there now are emerging some human studies. What are the challenges? Number one, knowing the stem cell source. If it's coming from you, it's safe. If it's not coming from you, you have to really be a bit concerned about where it's coming from. And again, it's important, if someone approaches you about stem cell therapy, ask them where are the cells coming from. Another issue is the quality of the stem cells. Quite often, if they process the stem cells too much, the stem cells are damaged, and they may not be able to cause regeneration or provoke regeneration because they're dead. So again, it's really important to know those things. Here's the only study so far that's registered in the clinicaltrials.gov website regarding stem cells and CRPS. This is a study out of Montana, I believe, and the point of contact is Dr. Alexander, and this will be on the slides that you'll get later on. This is a study involving RSD, CRPS, fibromyalgia as well. So the estimated enrollment is 100. The study started in last December, is going to 2019. And so what they're doing is they're taking fat cells from you, autologous fat cells, and then separating those out and giving them back to a concentrated form to see how that affects your nervous system to alleviate symptoms of CRPS. So this is the only study of its type so far in the States. So when it comes to interventional therapy or things with needles, what works? At the present, IV ketamine works. Not for everyone, but for quite a few people. Sympathetic blocks can work. Neurostimulation can be helpful. Scrambler therapy is interesting. Again, it's not big in the US just yet. Interventional pumps, again, procedure of late resort. And I think regenerative medicine really holds the key to the way we practice medicine today. I think that's something that's going to be very important for you, but not just yet. And concluding, our lack of understanding has made CRPS a difficult disease to treat, as you can tell me, I'm sure. But again, we found several things to be of help to you as we look deeper and deeper to try to get better results for you. But it's very humbling because we just don't know anything yet. Thank you.